Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm excited today to be talking to two family physician pioneers, Dr. Len Fromer and Dr. Scott Conard. Dr. Conard, would you like to go ahead?
Well, I tell you what, I'd like to defer to Dr. Fromer, and because I'm going to be asking him questions, and I really want the flow of our interview to be around his life history and his journey. So I think that this whole webinar or this whole podcast is going to be talking about his career. So Len, how about just doing a quick introduction of me so we can get on to more important things?
Okay, happy to do it. Scott and I met, I think it was at least 15 years ago. He is the most forward-thinking family physician I have ever met. Scott sees things today and thinks about what can we do tomorrow? How can we change things and revolutionize the position of primary care in the world of the American healthcare system? He has founded a company called Converging Health. It is the culmination of his efforts over long periods of time to bring together payers, providers, the different pieces, legs of the stool of what the system is built on, to make sure that value-based care, measuring how well we do in delivering services to patients, that value-based care is based on evidence and metrics. And when it's done well, we give a reward to the people who bring that great triple aim or even quadruple aim now as we go through the content of our discussion to the patients, and we base a system on the delivery of how good is the care patients are getting and at what cost. So I will stop there and let the content flow.
All right. Well, thank you, Len. And, you know, I think you and I are twin brothers of separate mothers because from the first moment I met you, I knew that you were a person who loved family medicine and loved people and loved to see how we could take the people that are practicing family medicine, and for the medical students or residents that are out listening to this and have chosen family medicine or thinking about family medicine, Len and I are two examples of people who love to care for people and want to make a difference, and we want to do well on that journey too. It's not just about working hard, it's about working hard and being able to care for our families and be very successful. And are very excited still today after having been in practice, or, you know, I say in practice, practicing family medicine. Now, Len, I know you're not seeing patients every day, but how long have you been a family doctor in terms of going to residency?
Going on 40 years, Scott.
40 years. So let's start by talking about your journeys. And I'd like to break this into three sections. And Len, that is starting off choosing family medicine, going to residency, and starting your practice. And you were actually trained up in New York, and then you moved to California and started off in an area where managed care really affected you all dramatically, and you built a group, and you were part of the leadership of that group. So phase one is family doctor, leader of primary care office. Phase two that I know you from, the first time I met you, you showed up in my office and said, Scott, what are you doing? And how do you do that? Because you've been very active with the California Academy of Family Physicians, and then the National American Academy of Family Physicians, and then really became one of the founding leaders of the value transformation inside primary care, and spent a couple decades going around and teaching family docs how to transform their practice from fee-for-service on a treadmill to a value-based. And you and I worked together there with a group of 500 doctors that you helped me lead into value-based practice, and we were very successful. And now, in phase three, you're actually taking all of this knowledge and saying, given the social determinants and the forces that we have in the United States today, how do we combine helping people live successfully as financially, socially, emotionally, nutritionally, activity-wise, and have them get great care at the same time? So you've taken it, put it all together in a really exciting, dynamic role as in Turner Impact Capital. So with your permission, let's break into those three sections, and give us a little bit about each of those phases of your life, and in a way that those medical students and residents listening can envision that being their career and the excitement and the gratification you've got through the journey.
Well, thank you. You make me feel exhilarated and exhausted at the same time for what you described. You are correct. It was so true. When I graduated medical school in New York City, 226 of my classmates, 5 out of 227 went into family medicine.
Wow.
Unbelievable. It was just a wake-up call for me to say, what is wrong with our system that we go through 4 years, we get exposed to every specialty under the sun in a traditional academic institution, and only 5 of us could find a way to say, that's what I want to do with my life. So, having experienced that, I decided to do my training and residency in California. I thought that, and it turned out to be true. There was much more of a movement out west to say, let's take the evidence we have that the most critical doctor in the system of all the doctors who are interfacing with patients has to be the family doctor. And let's put it into training, and let's graduate people from residencies who can go out into practice and make a difference, not just in the patients they see and the approach they bring with primary care and the love and passion we all had for it, but also can they start to tilt the system so that how we align paying for care, the people who buy the care, and the providers who bring it to the patients are all aligned with delivering high quality at reasonable cost across the population. So I chose to be trained in California. I finished my residency. I looked at the landscape and I said, you know what? I see something happening here called managed care that's going to make a big difference in how practices are organized, who owns the practices, how big are the practices, affiliation. So I decided to join a medical group that was embracing managed care, the revolution that happened in the late 70s, 80s, and 90s, this changeover to bigger groups, not only onesie, twosie, threesie docs, although that's perfectly reasonable now as we've evolved into the current system to be in that organizational structure. But I thought for the decade of the 80s especially, it was about big groups. It was about being able to sit at the table with insurance plans and be able to speak up for the value of primary care and the abilities we had and the training we had, and be able to negotiate contracts to take care of the members of that health insurance plan that we were contracting with in a way that allowed us to exhibit those skills and resources we had as family doctors to be the crucial element in that delivery equation. I was in that group for, 25 years. And
wow.
Somewhere along the way there, as a member of this group on the front edge of the managed care revolution, as the accountable care revolution, we can get into what that means, started to happen, I ended up in positions of leadership with my state and national academy, and ultimately in the middle of the movement to the patient-centered medical home model, and all the things that means around team-based, patient-centered collaborative care and the critical role family medicine plays in that. So, that's how I got to where I am.
Okay, so I want to, for the young minds that are listening to this podcast, I want to ask, just tease a couple quick things out about your career and the way you do things, because you went into practice to see patients and to go in and out of exam rooms. I mean, literally, your email is MD Welby. I mean, and Mark, we were talking, some of the young folks, probably most of the young folks don't know who Marcus Welby was, but he was the quintessential family doctor from the 1960s, or really, historically model, where he knew everybody he took care of. He, delivered the babies, raised the kids with the families, and he didn't have to take a really comprehensive history the way we do today when someone we don't know walks in the room, because he knew everybody he took care of so well. And so you and I both, my dad is Marcus Welby also, and he's a family doctor. And by the way, my daughter, as you know, Len, is in residency program to be family doctor. So obviously we have a strong commitment to that. And so you went into practice thinking you'd spend your career going in and out of exam rooms, seeing people and being Marcus Welby, and then something shifted. And what shifted? Because I think the young folks going to medicine, they look at it and they go, oh, it's a grind. Oh, I don't want to do that. Oh, I can't see myself seeing 20 patients a day for the rest of my life. And the truth is, most of us in family medicine, we start with that and we gain the experience and the knowledge and the wisdom, and then we allow our careers to blossom into different things. And yours certainly blossomed. So what's your attitude? Like, what is the defining way you think that had you go into family medicine and be carried by the wave of innovation and making a difference?
Simple, Scott, you say it very well, but it's a simple equation. I was going home every day as a family doc, seeing 25 to 30 patients a day with a full panel of about 2,800 active patients. I was going home every day frustrated because I couldn't do what Marcus Welby could do as one person in the mythical, fictional character he played on TV in the 1970s. The thing was, he cured every patient. He knew everything about every patient, but he only saw one patient a week. That was literally in the show what happened.
Yeah.
But it tells a story. He didn't see 28, 30 people a day. He had time to talk to the patients. He had time to know the patients and their families and address the many things that add to the patient's biologic, genetic determinants, add to that the social determinants. In the world of managed care in America, primary care, wanting to do the passion and love we have for wanting to do what makes a difference now, we know now from strong scientific evidence that social determinants and dealing what's going on in people's lives outside the healthcare system as they walk back into the community out of our offices matters just as much as their DNA, probably matters more. So frustration led to action. And what I said was, I can help 25 to 30 patients a day. I can make a difference over the course of a lifetime in the people coming and going, maybe a total of 10,000 patients in my practice lifetime, unique, different patients. But you know what? There's other ways to help people. If you can make the system better, if you can take your knowledge and skills and passion and love for family medicine and knowing that it's the most critical piece of that equation and bringing great outcomes to patients, great triple aim scores of outcomes, patient experience, and population cost, then that matters just as much as seeing somebody in an exam room. And I took that frustration and started to work in leadership and saying, family docs are the best ones positioned to be the leaders of this evolving system that is changing so rapidly in America into this managed care, accountable care equation, and particularly now in the last decade of this movement from volume-based healthcare of how much care are we giving people, getting paid for that, to how good is the care and at what cost, and getting rewarded when we do a better job with that. So I started to get involved in leadership with our state and national chapters, academies, and got involved in the transformation movement of helping practices transform practices of any size and deal with the social determinants. One of the key metrics that I want to quote, which we just put together in my current, the hat I'm wearing right now, and running a team of people building primary care infrastructure in underserved communities around the country so that family docs can do their thing, do it well, and get rewarded for it. We just had our investors meeting, and we put together data for reporting to the investors on how we're doing with our fund. In that process, I can tell you that in the 1 year that the fund has been up and running, we are already making a difference in the lives of 44,000 people. In my whole practice lifetime in front lines, which is great to do, I was maybe able to help 10,000. 1 year, we've got 44,000 that's already benefiting and getting care in the infrastructure we're building and making possible for primary care to flourish. So, many ways to skin the cat.
Yes. Well, so congratulations, and I want to just put a cherry on top of what you just said, and there are two things that I heard you say. One is you have to do the work, you have to see the patients, and you have to to gain the experience of being an engaged full-time or relatively full-time primary care doctor, and because you can't just skip from residency training to being a leader, you've got to do the work, and you did the work, and you, in that process, identified where the system worked and where it didn't work, and where it didn't work, you let that fuel you. Dissatisfaction breeds change, and you let that fuel you to become more and more proactive instead of getting depressed and drinking and drugs. And, we talk about burnout all the time right now with physicians, and a big part of that is feeling helpless and hopeless about the impact they can have on people. But you did the opposite. You said, I'm going to use that energy to drive me. And then you let go of controlling everything in your world, which I think is something that's very hard for young doctors. And you said, I'm going to focus on the influence I can have, with the principle being that how many people do I influence every day through other people and directly, and how do I continually influence more people? And you let go of having to control everything in your environment. I think from a leadership perspective, when you quit trying to control everything and you start to be influential, be the CEO, where you're pointing, go here, go here, go here, and you're leading teams, and you're not trying to do everything yourself. Young providers tend to think, if I don't do it myself, it doesn't get done properly. At some moment, you've got to let that go and say, I need to create accountability of my team, but the less I do and the more I support them in doing it well, never do something that somebody else can do just as well as you, and everybody works at the top of their license, then the more influential we're going to be, the more lives we're going to impact. And as my dad always used to say, Scott, if I made this one pencil and it cost me 50 cents to make, and I sold it for $1, how much money would I make? 50 cents. If I take the same pencil and I sell it to 1 million people, how much money would I make? $500,000. So I think part of the frustration that young clinicians have is they limit the number of people they influence, and as a result, they limit what's possible in terms of the return on their investment. I don't just mean money, I mean satisfaction, I mean work-life balance, and many of the emotional things that we talk about, because they're trying to control too much and don't make that shift to influence. But you did that incredibly successfully and became a real leader in family medicine in the United States. And now you're continuing to do it with Turner Impact Capital. So let's talk a little bit more about that if we could. And would you share with us the history of Turner Impact and where did it come from, who invests in it, and what's the philosophy of it?
Sure, happy to, and thank you for your comments. I would tag on to what you said before I go into the history of Turner. The burnout issue we're realizing now, and this is so critical for primary care, it's really a moral dilemma issue. What causes burnout for our colleagues who have a passion for primary care, for the residents coming out of training, for the medical students thinking about their specialty, the burnout issue is really the dilemma we face when we realize that the reality of practice in modern American healthcare is the autonomy and independence for us to be directly connected to the patient and make a difference in their life, patients and their families, is abruptly broken by all of the other system influences that get in the way. And I would say as a factoid of advice, if you will, to people listening to this who are thinking about primary care, who are in primary care, we always talk about risk in the managed care, accountable care equation. Do you want to sign a contract where you take risk? I would ask people, whenever they see the word risk, change it to opportunity. Change the wording literally as you see it from risk to opportunity. If you take a contract and you have an opportunity to be measured on how you're delivering the goods in the end, how you're delivering on triple aim, how are you as a physician or whatever position you're in being measured, what benchmark of excellence you get compared to, and you will immediately start to come up with workable solutions that revolutionize what's going to happen the rest of your life and revolutionize what you can do with your patients that you take care of. You will start to see ways to break that terrible vicious cycle of insurance companies getting in the way of what you want to do with your patients, the government getting in the way, and you will start to seek to take that opportunity to sign contracts to control the equation. When you take the value contract, you also make sure you get the opportunity to control what will allow you to get those great results. So what did I do in my life to get to that point? I looked around and I said, you know what? If I could build infrastructure, literally bricks and mortar, in communities that needed it the most around the country, that were underserved with their health care, that were designated medically underserved or health provider shortage areas, what vehicle would there be that would be an opportunity to put together funds to be able to invest in building that infrastructure and then focus what we were building on primary care in those communities? So we don't want to build hospitals. We certainly don't need more of those. We just have an imbalance of where they are and where they're needed the most. But we wanted to build outpatient community infrastructure. Turner is a family of investment funds. Healthcare is our third of three. First fund was education. What do we do with education? Now built 105 public charter schools in underserved communities around the country, communities that had either no public school that was performing or no public school at all, and the students had to go distances to get to classes. We built 105 schools. We have about 56,000 students in those schools. And I think if we were a school district, public school district, we'd be the 26th largest school district in the country. Second fund, housing. So you think about the social determinants that we talked about for healthcare. So what are the three big ones? Well, you got where do people live? What kind of education do they get? And food. And we're going to be working on food next. But right now we have the three that I'm going over, which is second one is housing. Affordable rental housing so people aren't spending more than 30% of their take-home pay on rent. We buy and preserve and enrich workforce housing. The third fund, healthcare, building the infrastructure so primary care can flourish. About 3 years ago, what happened was I was introduced to the people who were in the financial Wall Street investment world who said that, you know, they wanted their money to not just make money, they wanted it to do good and do well at the same time. Social impact investing. And they had this idea that you could actually do it in healthcare and do it in communities that were underserved and be able to make ends meet and thrive actually financially while you did that. So I started working with them first as an independent consultant, and as time went on, more and more work, and finally they basically made me an offer I couldn't refuse to come full-time and run the team that's doing the healthcare initiatives in the company. And that's how I got here.
Wow, that's exciting. Now, I want to take and set this up a little bit more. For those young minds that are listening to this and haven't read the book, How Healing Works by Wayne Jonas, it's a book I think we should really encourage you to read. And basically, one of the many points he makes, and a quick snippet, he was a doctor who worked in a very traditional military system, and then he became the leader of the NIH Integrative Medicine program when it began, and traveled the world to ask, you know, what's going on around the world in alternative and other traditions that might work. And he was basically very cynical and in a positive way, and he also wanted to see the evidence. And over time, it transformed his view of how healing works. And one of the big points he makes is from the data we have today, about 15% of a person's health is determined by their health care, but 40% is their self-care, and 45% is the social determinants, with the last 5% being environment. And if you're going to really help people be healthy and heal, you cannot just focus and operate within the 15% without taking the 85% into consideration. And Len, you were one of the first doctors that I ever met that understood that and really started to lean into what does it look like if we create we take the social determinant situation of many people who aren't able to thrive and transform that, and then also put great health care with that. So give us some examples of how in real life the Turner Impact Fund with your medical leadership is doing that.
Sure. So we have opened 15 centers in the little more than a year that we've been in business as a fund across the country, across America, from Florida to the Northeast to the Midwest to the Southwest and Pacific Northwest. Those 15 centers are serving primary care in every instance across different types of programs that are in our health system. One of the biggest ones being Medicare Advantage. So for those listening, Medicare Advantage is an offshoot of the traditional Medicare program. Incredible rapid growth in the last decade, where now there's over 20 million Americans who have Medicare Advantage as their Medicare coverage rather than the traditional Medicare fee-for-service program. The unique difference in that, more than anything, is that those programs in Medicare Advantage, the government contracts with insurance plans. Those insurance plans contract with networks of physicians to deliver care to the members who choose that type of coverage for their Medicare benefit. It is a per member per month capitated payment that goes from the government to the health plan and on to the doctors. So we build the centers in communities that no one has looked at before and said, we need primary care in these communities. So we build Medicare Advantage centers, and we partner with clinical healthcare provider networks, big, large medical groups, the doctors who are contracted with integrated health systems, IPAs, independent practice associations, to take care of patients in those centers. We have 12 of those open already, and the balance of the 3 that are 15 for the first year include federally qualified health centers and clinics, community clinics that we build with an FQHC designation in communities that had no access to healthcare before we built this center, and the PACE program of all-inclusive care for the elderly, an amazing model of what our system should look like for frail elderly seniors who would otherwise need a nursing home if they didn't have the PACE center to go to. So we build these centers to partner with clinical entities to put primary care teams into position to make a difference in the lives and outcomes for the patients who are seen there.
Wow. So we're going to run out of time because, you know, you and I never have a shortage of things to talk about. And so we've only got a couple minutes left. Let's try to wrap this conversation up, Len, by talking to those young minds, those primary care providers, and talk to them about the opportunity that you see coming over the next 5 years for them to get more involved either at one of the centers you're doing, or in doing things like you're doing in the marketplace. And how should they be open to this? Like, what should they just kind of keep their ear to the ground and look or listen for?
Sure. Fantastic question, Scott. I would say they need to pay attention. Every one of us needs to pay attention about things that are happening at a federal, state, and private insurance level. What's happening in the employer marketplace, what's happening in the government programs marketplace in healthcare. We all focus, as we need to, of course, on is Obamacare going to be there or not? Is it going to get amended or not? What's going to happen with that? But while that's critical, there's also something critical happening, that within the current administration and Congress, CMS, Center for Medicare and Medicaid Services, through statute and regulatory change, is very much embedded in pushing towards, as fast as we can, this movement from volume to value in our country and our healthcare. This movement from CMS saying through the government programs, particularly Medicare and Medicaid, but a few others, and through private, because that filters down through then private commercial insurance, we have to stop paying for how much care people are giving, get beyond the CPT code, get beyond volume-based payments into what was the value of the care provided. sign a contract with those payers. Think about it for the young minds out there, the opportunity to sign a contract to shift the risk for the budget for the care somewhat or all, depending upon what structure you're in, so you know you can manage that risk, into shift that risk onto the provider side and say, I've got that opportunity, now I have to manage it, I have to create, and I have the structure in the program to create the rules around which I see patients. And CMS has most recently, you can go back number of weeks, number of months, but every day things are changing rapidly where CMS is supporting and the private insurance industry is supporting this movement by changing some of the rules. The recent change by CMS to the new primary care payment model to run a demonstration project for the next 5 years, to announce that they are literally allowing any primary care doctor in America to interface with this model. It's voluntary, it's not mandatory, but if you interface with this new payment model, the opportunity to manage that risk, that contract, that budget, and the freedom to get past that moral dilemma which leads to burnout, to be able to not have anybody in between your relationship with your patient and take the knowledge you have and the skills you have and address what that patient needs, to go upstream really and say, we're not just mopping up the flood when it hits the floor in healthcare when the patient's sick and ill and needs rescue. Yes, we have to be great at that, but let's stop the flood on the floor by going upstream and turning off the spigot up above and do some primary prevention, even secondary prevention. And with this massive population wave of seniors, 10,000 people turn age 65 every day in America, and that's going to continue for the next 11 years because of the baby boom generation. With that massive wave of chronic illness that goes along with that, move to a system where we measure and prove we're doing a great job in managing those chronic diseases. Think about that as you think about your future as a physician and the ability to take the opportunity to manage that patient and population, do it in a way where there is no moral dilemma of influence on you. I think that's a good place to start, and watch what's happening with regulations coming out of the government programs and the announcements of what the private health insurers are doing around giving that opportunity to primary care docs to take that and run with it.
That's fantastic, Len. Thank you for that. And, the last thing I'd say, just to add on to that a teeny bit, is we've been in this bubble where specialists have been paid 3 and 4 times, 5 times up to, of what a primary care doctor is. It's very gratifying to me to see what primary care is being paid, doubling over the last about 10 years. And the specialist pay is actually coming down in many cases because it was artificially elevated. And so for those of you listening to this podcast are thinking, well, I got to be a specialist to get paid well, that's going to go away because they've discovered that primary care is actually what provides the greatest value in the healthcare delivery system. That's not to say that specialists aren't valuable. That's not what I said. But the primary care is the key to success, and they need to be rewarded. This is not the first time this has happened. It's happened around the world at different times, and inevitably what happens is somewhere between 30 and 50% of the specialists go back into primary care, and the primary care doctors gain equal footing with the specialists economically, and we're watching that happening. And so I hope that the young minds will pay attention to what you're talking about, because with payment reform becomes primary care recognition, and we already know you have a great relationship with people when you're in primary care. You can make a huge difference and have very gratifying long-term relationships. And now economically, there's no disincentive, or it's becoming less and less. So it is, in my opinion, and my father and my daughter and you, Len, I know we all agree that it is an incredible gift to be able to serve people as a primary care provider.
Oh, totally agree.
So I'm going to
well
jump
said,
in.
Scott.
And this is Larry. I'm going to jump in. I have to say, this has been just a real treat for me to listen to the two of you share your perspectives. And I want to thank you so much for spending your time with us this afternoon.
Well, Larry, thank you for asking us to be a part of this. And I know Len and I both view ourselves as being available to people, and anybody who would like to discuss this further or learn more about the Turner Impact Fund or talk about primary care, there'll be many opportunities, and we'd love to do it with you.
Great. Thank you very much. Thank you, Len.
Scott.
Thank you,
Larry.